Thank you, Charisse. Our time now in Manila is 12:05 p.m. and I'm speaking from the video conferencing room of the UP Manila, Padre Fauras Street, Ermita, Manila. Today's topic is novel therapies for lung cancer. The objectives of today's webinar are: number one, have an overview of the incidence and mortality burden lung cancer has on the adult population. Two, learn how the advances in science have dramatically changed the approach in the diagnosis and treatment of lung cancer. And three, remain hopeful that newer discoveries will have a positive impact with regards to improving survival in patients with lung cancer. Today's speaker is Dr. Conrado Lorenzo III. Dr. Lorenzo is a graduate of the UP College of Medicine. He did his residency in internal medicine at Hahnemann University, Philadelphia, Pennsylvania, and did his fellowship in hematology and oncology at University of Texas, Southwestern Medical Center, Dallas, Texas. He did his master's in business administration, health, at the Ateneo Graduate School of Business, Makati. He was a director at Makati Medical Center and former section head of medical oncology at Asian Hospital and Medical Center and St. Luke's Medical Center. Without further ado, may we now call on Dr. Lorenzo.
Thank you for your warm introduction. My chosen topic for today has to do with novel therapies in the treatment of stage 4 non-small cell lung cancer. The advances in the treatment of stage 4 lung cancer has been progressive and dynamic as a result of an increased understanding of tumor biology and the mechanisms that cause tumor growth. For a very long period, treatment was mostly empiric in nature, with reliance on data coming from clinical trials, but lacked the specificity that is so important in treatment selection. The discovery of molecular profiling has changed the treatment approach to lung cancer and has resulted into improved clinical outcomes. It is the objective of this lecture to give all of you a better appreciation of the advances happening in the field of medical oncology. Non-small cell lung cancer accounts for approximately 85% of all cases of lung cancer and continues to be the leading cause of cancer-related mortality in both men and women. In the Philippines, lung cancer is number 1 in incidence among men and number 3 among women, next to breast cancer and cervical cancer. It remains to be the number 1 cause of mortality in both sexes. Approximately 40% of patients present at an advanced stage, with the majority presenting with the adenocarcinoma subtype. In the US, about 40% are diagnosed with stage 4 disease at initial presentation. I think these numbers are a little higher here in the Philippines. 160,000 deaths were reported in 2012, a figure comparable to prostate, pancreas, breast, and colon cancer combined. The figure on the right illustrates the mortality burden lung cancer brings and equals that of prostate, pancreas, breast, colon, which is quite an alarming statistic. The current options for the treatment of non-small cell lung cancer has changed dramatically with the discovery of newer and more novel anti-tumor drugs. In the past, cancer treatment was limited with the use of conventional chemotherapy, which has intrinsic limitations given its modest efficacy and accompanying toxicities. The approach to treatment is decided based on empiric data with reference to clinical studies that would, at best, guide oncologists in selecting treatment options. Surgery remains the mainstay of treatment in patients diagnosed with early-stage disease, whereas combined modality treatment with the use of concurrent chemoradiation is primarily reserved for patients in the locally advanced setting. Systemic chemotherapy has remained the cornerstone of treatment for patients with advanced disease with modest benefits in spite of the introduction of newer agents. The discovery of targeted therapy with the use of molecular profiling has now afforded cancer patients with improved treatment outcomes and with manageable toxicities. Customizing treatment, now based on histology and molecular profiling, has now become the standard approach to patients diagnosed with lung cancer. The presence of molecular markers like the EGFR mutation, the ALK gene rearrangements, the T790 mutation, the PDL1 expression now allows oncologists to make more specific treatment recommendations. And with the recent approval of immunotherapy, the treatment paradigm for patients with non-small cell lung cancer has now become even more promising. For several decades, chemotherapy has been the mainstay of treatment for lung cancer, but with modest benefits accompanied by untoward side effects. We will briefly review how cytotoxic chemotherapy works with its modest gains and its inherent limitations. Chemotherapy works by inhibiting cell division, a property characteristic of cancer cells, where cells are seen to actively divide and undergo uncontrolled proliferation. Normal cells are not always dividing at any given time. Hence, the degree of damage it inflicts is much less compared to cancer cells. The choice of chemotherapy is determined by several factors, which include a patient's age, performance status, cost of treatment, patient expectations, and the presence of underlying comorbidities. Although there are several approved chemotherapy protocols, platinum doublets are the mainstay of treatment and have been established to prolong survival, improve symptoms, and yield superior quality of life in selected patients compared to best supportive care. Triple combination has been shown to increase response rate without necessarily improving overall survival. So most oncologists would not resort to giving more than 2 chemotherapy agents unless absolutely necessary. The prescribed number of cycles is anywhere from 4 to 6 cycles, after which no survival advantage is conferred. Cytotoxic chemotherapy has its limitations, with responses that are usually brief and often unpredictable. The more common platinum doublets used in clinical practice include a platinum and pemetrexed combination, a platinum gemcitabine, a platinum docetaxel, and a platinum and paclitaxel. The cost of treatment is on the right side, with platinum and pemetrexed costing about 170,000 pesos every 3 weeks, which is quite prohibitive. Although the platinum doublets have remained the mainstay of treatment, the benefits one gets remain modest, with an overall response rate of 35%, time to progression of 4 to 6 months, a median survival of 8 to 10 months, with a 30 to 40% 1-year survival rate and a 10 to 15% 2-year survival rate. Now, the second class of drugs, targeted therapy, is a new class of medications that is used against lung cancer and brings with it the advantage that it confers with it some degree of specificity and with more tolerable side effects. Targeted therapies, specifically the tyrosine kinase inhibitors, or sometimes called the TKIs, allows oncologists the benefit to now tailor treatment based on the presence or absence of specific molecular markers that may be present in a patient's tumor. Therefore, treatment is no longer just based on empiric findings, but rather, treatment recommendations have become more specific to a particular patient, hence becoming more personalized. Targeted therapy refers to drugs that bind to a specific target on tumor cells that prevent its activation. It works by competitively inhibiting various cytokines that would otherwise activate critical steps that lead to tumor growth. Examples of these targets are the EGFR and ALK proteins, and determining the presence of these target mutations have now become standard in the diagnostic approach for patients with lung cancer. Molecular profiling allows the identification of what we call driver mutations that, when present on tumor cells, carries with it both prognostic and predictive significance. The presence of somatic mutations involving the EGFR in patients with non-small cell lung cancer actually leads to its constant activation, favoring uncontrolled cell division and tumorigenesis. The other identified mutations include the EGFR, the ALK, the KRAS, and the T790 mutation. The presence of the EGFR mutation predicts response to gefitinib, erlotinib, and afatinib, while the presence of the ALK gene rearrangements predict response to crizotinib, and the presence of the T790 mutation confers secondary resistance to TKIs and predicts the response to a third-line TKI called osimertinib. The presence of KRAS confers a poor prognosis and usually confers primary resistance to TKI therapy. EGFR mutations act as oncogenic drivers that, when activated, sends off a variety of signals that trigger a cascade of events. The presence of various cytokines present in the tumor environment promote the activation of the EGFR protein that leads to the following. It causes cell proliferation, tumor invasion, angiogenesis and metastasis, inhibition of apoptosis, which all are characteristics that would promote tumor growth. Among the receptors, epidermal growth factor receptor is the most widely studied receptor, which has led to a deeper understanding on the mechanisms of tumorigenesis. In 1986, Stanley Cohen won the Nobel Prize for its discovery, but it was not until 2004 where two pivotal trials demonstrated remarkable results that triggered further clinical studies. The prevalence of EGFR mutations is much lower in Caucasians as compared to either Asian counterparts. It's greater than 50%, which brings the point that all Filipino patients should be tested for the presence of the mutation. In a published report, Filipinos in particular have greater than 50% chance of harboring the EGFR mutation, which strengthens the argument, again, that all patients with non-small cell lung cancer of the adenocarcinoma subtype should undergo molecular profiling. The most common type of mutations encountered involve deletions in exon 19 and substitutions in exon 21. The tyrosine kinase inhibitors are a class of drugs that prevent the complete activation of the TKI pathway by preventing dimerization and autophosphorylation, both of which are essential steps in the downstream signaling that leads to tumor growth. It works by binding to the intracellular domain of the EGFR protein located in the cell cytoplasm. And the classes of drugs that are used primarily are the EGFR TKIs, which have three, the gefitinib, erlotinib, and afatinib, and the ALK TKIs, crizotinib and ceritinib, respectively. So this is an illustration where the tyrosine kinase inhibitors acts on the intracellular domain of the EGFR protein, which disallows the binding or the dimerization of the two EGFR proteins. Hence, proliferation, invasion, metastasis, will be prevented. The examples of the tyrosine kinase inhibitors used are erlotinib and gefitinib are first-generation TKIs. And as you can see, the response rates for erlotinib is 83% compared to 36% of compared to that of chemotherapy, with a progression-free survival of 13.1 in favor of erlotinib versus chemotherapy of 4.6 months. Gefitinib likewise has a response rate of 71% compared to chemotherapy's response rate, which is 47%, with a 9.8 progression-free survival versus 6.4 months of that of chemotherapy. The cost of treatment can still be prohibitive. It's about $125,000 to $130,000 per month. This table is a meta-analysis of the pivotal studies comparing EGFR TKI versus chemotherapy. And what is common to this table is you will see that the response rates of the TKI far outperform that of chemotherapy. The response rate is about 70% versus about 50% with chemotherapy. And that true is with the median progression-free survival, where you get an average about 9 to 10 months compared to 4 to 6 months with chemotherapy. And all these studies has now placed the use of EGFR TKI as the first-line treatment for patients harboring the mutation. It no longer is used in the second-line setting. Now, the other important target protein relevant to non-small cell lung cancer is the anaplastic lymphoma kinase, or the ALK gene molecule. And the presence of this protein confers resistance to any of the other EGFR TKI medications. And in fact, we use crizotinib as first-line treatment in patients with the ALK positive tumors, where it confers a 60% response rate, and it actually works with patients with brain metastasis. The ALK and EGFR positivity are often mutually exclusive. So if you're ALK positive, the likelihood that you are EGFR positive is small. And with the ALK gene protein, as little as 2 to 7% of patients possess this rearrangement. So it's very rare compared to that of the EGFR. Now, the third and the newest class of drugs is called the immunotherapy. And this is the interest of the lecture. Immunotherapy is the newest rock star in the treatment of lung cancer and brings with it a renewed sense of excitement. Now, the concept of harnessing the body's own immune response, or the own immune system to combat cancer cells, has challenged many physicians and scientists in the past. Early immunotherapy trials focus on the use of vaccines to teach the body's immune system to recognize immunogenic proteins on cancer cells. Interferon and interleukin have been used in clinical practice to stimulate non-specific cytokines to boost the immune response against tumor. This is used in renal cell carcinoma and in melanoma. Unfortunately, these forms of therapy have failed to produce reliable, durable, and reproducible results. Now, a recent breakthrough in the treatment of lung cancer has taken center stage with the discovery that the interaction between PD1 and PDL1 prevents the body's immune system from doing what it is programmed to do, which is to recognize and kill tumor cells. Now, PD1 is a protein which is found on the cytotoxic T cell, whose action is tightly regulated and plays an important role in immune surveillance. Now, the PDL1 protein is expressed in various types of cancers and is upregulated in response to the pro-inflammatory cells such as interferon, tumor necrosis factor, GM-CSF, and other cytokines present in the tumor microenvironment. Now, how does it work? When PDL1 on the surface of cancer cells bind to the PD-1 on the surface of the cytotoxic T cell, an inhibitory signal is transmitted which reduces cytokine production and suppresses the activity of cytotoxic T cells. So what essentially happens is the interaction between PDL1 found in the cancer cells and the PD-1 on the cytotoxic T cells does not allow the cytotoxic T cell to recognize the tumor as foreign. Hence, they sort of are camouflaged with the action of the cytotoxic T cell. So as a result of the interaction, the tumor cells are able to escape recognition from the body's own immune system and is allowed to grow. So this is a cartoon illustration. To your left, you see that when PD-1 on the T cell binds to the PDL1 on the tumor cell, the actions of the T cells are inhibited and hence cannot kill the tumor cells. The action of the checkpoint inhibitors, as you will see, the binding of the checkpoint inhibitors disrupts the relationship or the interaction between PD-1 and PDL1. Hence, it allows the T cell to carry its normal function. So the two anti-PD-1 antibodies, nivolumab and pembrolizumab, have been recently approved for the treatment of non-small cell lung cancer that now is used, that has progressed after first-line treatment. They bind to the PD-1 receptors on T cells, preventing the PD-1 from binding with PDL1. So this results to removal of the inhibitory signal, allowing the cytotoxic T cells to inflict damage to the tumor cells. Now, pembrolizumab, with its brand name Keytruda, is a monoclonal antibody which binds to the PD-1 protein on T cells, blocking its interaction with the PDL1 protein found in tumor cells. Keytruda was granted FDA approval last October of 2015 for the treatment of non-small cell lung cancer whose tumor progressed after platinum-based chemotherapy. In the Keynote 010 trial, or in the Keynote 001 trial, a PDL1 expression assay was likewise developed to determine whether the degree of PDL1 expression on tumor cells translates to a higher response to Keytruda. And preliminary studies showed that the higher degree of PDL1 staining corresponded to a higher response to treatment. Now, this photo illustrates on the left, the figure A shows a PDL1 expression in tumor cells of less than 1%. Hence, you see the very faint staining as compared to figure C on the right, where PDL1 expression on tumor cells is greater than 50%. Keynote 001 was a landmark study published in the New England Journal of Medicine in August of 2015, whose objective was to determine the activity of pembrolizumab versus non-small cell lung cancer, and to see if the degree of PDL1 expression in tumor cells affect the rate of response. Of the 824 tissue samples taken to assess PDL1 expression, 23% showed PDL1 staining of greater than 50%, 38% showed PDL1 staining of 1 to 49%, and 40% showed PDL1 staining of less than 0.1%. So the findings also showed the tumor cells that expressed greater than 50% PDL1 staining had a higher response rate of 45.2%, progression-free survival of 6.3 months, and an overall survival that was not reached. And in patients whose staining was 1 to 49%, the response rate was still present, however, at 16.5%. And in patients with a PDL1 staining of less than 1%, the response rate was down to 10.7%. So the study conclusions in the KEYNOTE-001 study showed that Keytruda showed anti-tumor activity in patients with non-small cell lung cancer regardless of PDL1 expression, but patients with greater than 50% correlated with improved efficacy. Now, KEYNOTE-010 was another landmark phase 3 trial published in the Lancet, which compared the efficacy of pembrolizumab versus docetaxel as second-line treatment in patients with PDL1 positive non-small cell cancer with expression scores of greater than 1%. The conclusion of the study showed that the median overall survival for PDL1 positive patients on pembrolizumab was 15 to 17 months compared to that of docetaxel, which was 8 months. And the median duration of response with pembrolizumab was not reached, and the median duration of response to docetaxel was 8 months. Take note that docetaxel is one of the recognized good medications used for second-line treatment. So these results actually prompted FDA to approve the use of Keytruda for second-line treatment in patients with non-small cell lung cancer who progressed after first-line treatment. The average cost of pembrolizumab at 2 milligrams per kilo given every 3 weeks is about $216,000. That's in a 30-minute infusion.
It's 12:30.
This is an electron microscopy picture of the PDL1 on tumor cell bound to the PD-1 receptor on the cytotoxic T cell, rendering it inactive. So the conclusions with immunotherapy, the checkpoint inhibitors are now FDA approved for the treatment of non-small cell lung cancer who progressed after first-line therapy. Although the response is highest in tumor samples that have a PDL1 expression score of greater than 50%, measurable responses were also observed with tumor samples that have lesser degrees in PDL1 expression. Studies are ongoing to look into combination treatments where checkpoint inhibitors together with chemotherapy and/or targeted therapy with the hope to get better outcomes. And the results of the use of immunotherapy in the first-line setting is currently ongoing, and results are much anticipated. For the take-home message, the practice of medical oncology has actually witnessed rapid changes as a result of a deeper understanding of tumor biology. And with the evolution of the different classes of therapy, was briefly presented with the hope that further discoveries will afford cancer patients with better treatment outcomes. Thank you.
Thank you for that insightful lecture, Dr. Lorenzo. We would like to thank today's sponsor, MSD, and our media partners, the Philippine Daily Inquirer and the Filipino Doctor. We have 67 logged in now at GoToWebinar and 2 through live streaming. Before we proceed to our Q&A portion, let us have one of our panelists give her reactions. To introduce our reactor, Dr. Leonora Canizares Fernandez. Dr. Fernandez also graduated from the UP College of Medicine. She did her residency and fellowship at UPPGH. She did her master's in health professions education. She's a clinical associate professor at the section of pulmonary medicine at the UP College of Medicine and is a consultant coordinator of the Comprehensive Ambulatory Respiratory Rehabilitation or CARE program and Stop Smoking program at the Philippine General Hospital. She is the director of the UP College of Medicine Postgraduate Institute of Medicine. In 2010, she was also awarded Outstanding Researcher and an Outstanding Academician in 2011. May we now call on Dr. Fernandez.
Thank you, Marisha. Thank you, Dr. Rector, for that kind introduction. Good afternoon, everyone. In behalf of everyone listening to you, Dr. Lorenz I Garcia, thank you for providing us with the updates on lung cancer. I have been in practice for the past 19 years as a pulmonologist, so that reveals my age. And it is with pride nowadays that I can now tell my patients with lung cancer that there is hope. It was quite frustrating previously that only chemotherapy with or without radiotherapy were the sole options for our patients diagnosed with advanced lung cancer. Thus, the quality of life of our patients were very poor, and survival would usually range, I would tell them, Gary, as short as 3 months to just probably at the most 3 years. So now I would agree with Dr. Lorenzo that with targeted therapy and immunotherapy, these interventions have greatly improved the quality of life of our patients with advanced lung cancer and their survival as well. I'm proud to tell them that their survival can even go up as high as 5 to 7 years, and they sometimes succumb to other illnesses instead of lung cancer. So right at present, some patients are still able to work despite them having advanced lung cancer. This was not possible 10 years or 15 years ago. Our patients, though, however, would already have had a long trek of medical tests and consults before they reach the offices of medical oncologists such as Dr. Lorenzo. So before they're even given these interventions of targeted chemotherapy and immunotherapy, they would have had already at least consulted many physicians prior, and it is a crucial step in their journey as a lung cancer patient that they would have to be diagnosed early to maximize their survival rate, and if possible, for them to have been warned early on of the risks of contracting this dreaded disease so that he or she would have instituted preventive measures. So we are actually the gatekeepers. Us, the healthcare practitioners who would have initially seen these patients, and we are the ones who would eventually refer to the medical oncologist so that they can avail of this new advanced treatment so that they would have a better quality of life and improve survival rate. Thus, we play a very crucial role, us as healthcare professionals who would initially see these patients and probably initiate the screening for them to be eventually diagnosed to have lung cancer. And of course, foremost or more importantly, for us to have placed the thought of having or doing preventive measures so that they would not have this lung cancer in the first place. Now, unfortunately, or well, we can say smoking would still be actually the most important risk factor for our patients with lung cancer. And this is, of course, one thing that we really have to advocate for, that if we see a patient who is a smoker, then we have to advise them immediately to quit smoking as soon as possible. In the Philippines, we are proud to say that UP Manila has been at the forefront in the fight against smoking. The economic impact studies that we did in 1999 and 2000 under the able leadership of Dr. Tony Dance were the backbone for the approval of the Tobacco Regulation Act in the Philippines and the admired sin tax law. We can see here in this slide that the rate of smoking has actually gone down from 35% current smoking prevalence to as low as 28% in 2009. we are still gathering the data for this decade. So the National Nutrition Survey usually would be the one to initiate or continue these prevalence studies. So despite this decrease in prevalence, unfortunately, you can see here that among current smokers, 80% are still daily smokers. So there definitely is still the impact of nicotine dependence among our smokers. Many of our smokers would say that they feel it's easy for them to stop smoking, but our data here shows otherwise. So if we now spend time to ask that fifth vital sign, we like to term it as such, the fifth vital sign being asking the smoking status of a patient, and then if our patient would say yes, that they are smoking, and then we spend another 3 seconds just to advise them to stop smoking, that 3 seconds already increases the abstinence rate of our patients to as much as 10%. So I hope that we, as healthcare practitioners, wherever we may be right now, would spend that time to ask about the smoking status of our patients, and also now to advise them to stop smoking if they do smoke. Now, aside from in lung cancer, unfortunately, or we really can say the milieu is already changing. So as I mentioned, the smoking rate is going down, and we're now seeing 20% among our lung cancer patients having no smoking history at all, or they were not smokers. So now it is incumbent on us to ask also for other possible risk factors aside from smoking. Now, in this COPD prevalence study that we did here in the Philippines in 2009 and to 2010, we went to a rural area. This was in Nueva Ecija. We surveyed 3 towns there. And as you can see, one of the non-smoking risk factors for them to have the chronic illness called COPD, we see here that the biomass fuel exposure is 98.5%. So 100% were exposed to non-smoking risk factors for COPD. And this is the same risk factor also for lung cancer. So among the males, they worked as farmers, so they were exposed to smoke when they would now use fire to clear the crops and to plant their new crop. And the females would use wood to cook their food inside their houses. So 100% biomass fuel exposure. And we believe that this increased the incidence of COPD in this population. And I'm sure lung cancer was also increased in this population due to this non-smoking risk factor. In this same study, we also saw the other risk factors of exposure to tuberculosis, as well as to dusty jobs also, as you can see here. And these are also the same risk factors that are not related to smoking that would also cause lung cancer. So to summarize, please include in your personal and social history the inquiry on the second-hand smoke exposure among your patients, radon exposure if they are, occupational exposure to carcinogens like dust or fumes, and then, of course, exposure to wood fire smoking and burning coal indoors and, of course, in their job. And tuberculosis now is also considered as a possible risk factor for lung cancer. And here we can see, of course, that familial history of cancer would also predispose a patient to lung cancer. So the next question here now, if you're able to identify the risk factors, should be, how do we screen? I hope we try to screen early on. Usually we would tell our patients to have a chest x-ray taken, but unfortunately in the different studies done, it has been shown to have no proven benefit in detecting early on lung cancer. But for whatever it's worth, at least we should have I would still advocate the use of chest x-ray for probably an elderly patient or especially a smoker, so that at least it increases our chances. Although population-wide, this would not be the best diagnostic test for us to do for screening of lung cancer. What is advocated would be the use of low-dose chest CT scan to be done annually among those with risk factors. And these are the risk factors that we can see in the slide. So patients who are 55 to 74 years old, who have at least had a 30-pack year smoking history and continues to smoke or having quit within the past 15 years, or we can even do it earlier on at the age of 50, who has at least a 20-pack year smoking history and who has other risk factors for possible lung cancer. We can advocate for low-dose chest CT scan. Now, doing so has been shown to have a 20% reduction in mortality because of the early detection of lung cancer. So for us pulmonologists, for the pulmonologists probably here in the audience right now, what we also advocate would of course be to try to confirm the diagnosis as soon as possible. Once we detect the possibility of lung cancer, for you who are non-pulmonologists, kindly refer ASAP to a lung specialist or even to an internist, or even direct to a medical oncologist so that the confirmation of the disease can be done ASAP. In the Philippines, we have this unfortunate complacent attitude to say that the lesions probably seen on a chest x-ray is due to tuberculosis, and then we stop the diagnostic workup. So this is one thing that we advocate that we should not do. If there's a possibility of a nodule or a possibility of a malignancy, then please refer ASAP for confirmation. And the best way to do it is by tissue confirmation. And of course, we order later on the other molecular tests or molecular profiling that is advocated by Dr. Lorenzo for us to give the proper targeted treatment. So please do not stop at the diagnosis of TB. If there's a possibility of a nodule or mass, please go ahead with any diagnostic confirmation by getting a proper tissue biopsy. Here in the Philippines, we're able to do other tests to try to detect early on the presence of lung cancer. And as I mentioned, it is always a team approach when we already diagnose a patient to have lung cancer. We immediately refer to a medical oncologist as well as to a surgeon. Because as mentioned by Dr. Lorenzo, the best cure would of course be surgery if it's done early on and if it's an early stage of lung cancer. And then as I mentioned, there is hope for our patients even if they have advanced lung cancer with a targeted treatment that is already available, not only in the other countries, but here in the Philippines as well. It is an expensive venture, right, Gary?
Yes, yes.
Doing the molecular profiling and giving the targeted treatment. But for those patients who are able to do so, it really benefits them a lot. Thank you.
Okay, so now we are opening actually the floor for the question and answer portion. And let me see, we have a few questions. One for, I guess, whoever of our panelists would like to answer this. Does immunotherapy work for patients with adenocarcinoma of the lung with metastasis?
Yeah, the use of immunotherapy, for lung cancer in this case, it actually works for patients it works best for patients who express the PDL1 expression of greater than 50%. And it does treat not only the primary lung cancer, but it also treats the other areas of metastasis, because this is a systemic form of treatment, so it is not basically focused for just the primary. So yes, for adeno, it works in a systemic manner. And that's basically why we use it sometimes in combination with any localized treatment.
Okay, thank you, Gary. We have actually a question from one of our colleagues in the US who is a medical oncologist as well, Dr. Florence Arnold. She's our classmate there. And she's asked this question. Thank you, Gary, for that. I'm sorry. Wait, sorry, there was a glitch here. Okay. Excellent talk, Gary and Lenny. Gary, I'm impressed that you included drug costs in your talk. I'm curious to know if molecular testing and the price of medications are cost prohibitive for the Philippine population. I assume chemotherapy would be cheaper than targeted therapy or immunotherapy. So I guess what are your comments with this, Dr. Gary and Dr. Len?
Yeah, you know, I think anywhere, anywhere in the world, when something new comes in, there always is a cost that comes to it. I think it's not only the medications, as you mentioned, but it's actually the correct and orderly testing of the tissue specimen. And I think it's very important that we embrace that there is a multidisciplinary meeting, especially including the pathologists, because we do not want to treat this in a shotgun manner, or we just get, we send for all the molecular markers for the sake of doing it. So yes, it is expensive. Here some of the drug companies are partners when it comes to this, and they facilitate some of that testing to try to bring the prices down. The cost of medicines can be very expensive. Targeted therapy is about 120,000 a month's worth of treatment. The immunotherapy is as much as 200 to 400,000 each treatment every 3 weeks. So although we get better results with the new medications, there's a new, something that I probably define as financial toxicity. It's no longer too much the treatment, but it's the cost of treatment. And sometimes you see patients don't even know what to pray for, because as much as they're able to control their disease and make cancer a chronic disease, it comes, of course, with continued treatment and continued cost. So that is the dilemma we face in Manila, where most of the treatment is out of pocket.
Okay. A question for Dr. Fernandez. Are there good programs for smoking cessation in the Philippines? Also, are doctors sending patients with significant smoking history for lung cancer screening with low-dose CT scanning?
So we do have most of the tertiary centers here with a pulmonary training program. So there are 13 have proper smoking cessation programs, but all of us really experience a decrease in the enrollment. So that's our problem. Many Filipino patients do not like to go to centers for smoking cessation, especially with the traffic here in Metro Manila. So at least we're working now hand in hand with the Department of Health. We're trying to innovate and make it more, at least we can get more patients who smoke into the smoking cessation program. But there are at least 13 smoking cessation programs that are multidisciplinary in nature. The other problem is the lack of pharmacologic treatment for smoking cessation here in the Philippines. We only have varenicline, and it was only recently launched again, the presence of a nicotine lozenge. And varenicline, for example, is also expensive as a smoking cessation drug here in the Philippines. Now, in terms of the cost of treatment and probably the diagnostics here in the Philippines, for example, if I have a patient whom I suspect to have lung cancer, and then I would subject them, for example, to a percutaneous CT-guided biopsy, and then for them to have the molecular profiling, the CT-guided biopsy more or less would cost them around 30 to 40,000. And then the pathologists usually do not do the immunohistochemistry staining immediately. They would want to have first the histologic staining, and then only then will they do the molecular profiling. So the usual immunohistochem would cost around 3,000 here, and then the ROS1, for example, is only available in 2 institutions right now. And then the EGFR and the other molecular profiling would cost another 6,000 to 10,000 for a patient. So that would just be the diagnostic test. And then, of course, now the expense of the surgery and the chemotherapy. Now, in terms of using the low-dose CT, this is still starting to become popular here in the Philippines. Even our society, the Philippine College of Chest Physicians and the Medical Oncology Society, have not really made a statement yet that this is first line to be done for cancer screening. We've been having dialogues with the Department of Health, and they've looked at, of course, the cost estimate. They cannot shoulder it. So at present, at least in their what we call the ABC package, at least they put the chest X-ray. That's the only thing that they can afford right now as part of the preliminary the screening for patients who might be suspect or would have the risk factor for lung cancer.
Dr. Fernandez or even Dr. Lorenzo, could you comment on the effect of third-hand smoke? Is it really a risk factor for lung cancer?
Third-hand smoke is not yet proven to be a risk factor for lung cancer. Even second-hand smoke is considered as a putative and not yet really a definite risk factor for lung cancer. But definitely we've seen, of course, many respiratory symptoms to be increased with third-hand smoke and even e-cigarette use. So that's one very controversial field right now in the field of pulmonology.
Dr. Lorenzo, in our clinical setting in the Philippines, just like, for example, breast cancer, we can do some detection of genetic mutations. Do we actually have standardized tests for lung cancer to detect cancer with good sensitivity and specificity, as a predictive marker to initiate more intensive screening?
Not that I know of. No, I think basically it's not very familiar. We do not have a specific gene that has been globally embraced to be used for screening purpose. I think it's really the lifestyle, the smoking history, and what Lenny discussed earlier when we institute the CT scan for screening.
Okay. What about, do you have any comments about the use of herbal medications? Are there any promising herbal medications in the market that may be adjuvant treatments to lung cancer aside from this, the pharmacotherapy or immunotherapy that you have discussed?
That's often asked by a lot of patients. And my stats to that is really I don't have too much knowledge about it. There's just too much knowledge on the Western world for me to catch up. You see it prevalent. Many times in small print they say no therapeutic benefits. No? So even that question has to be clarified because it's a unmonitored world out there. And when you say alternative medicine or in this case herbal medicine, there probably are true advocates who apply science to it to find out where this really has an effect. But how do you differentiate those who are just basically doing out for monetary gain?
I would agree with Gary regarding that, and so far there really are no good studies to show that they would have the proven benefit. Many of our patients though would ask for it,
Yes,
so
yes.
that's really a dilemma for us. And then of course we know that they're quite desperate also, and we take that into consideration, of course, when they ask us about it.
It becomes so difficult because even we who practice science, so to speak, we can never promise patients results. We can only promise them good judgment, and it makes us very vulnerable because it's not our style to critique because it almost sounds like self-serving, and we see it in social media, we see it in the newspapers. So many people promote it, and sometimes I'm so tempted to not remain mum about it, but then again, it has that it becomes self-serving. So I'd rather not, and I just wish that we have more responsible marketing around, and that the societies are able to send a message that we're dealing with cancer. It's still best to be evidence-based.
Okay, so I guess we don't have enough time anymore for more questions. So I'd like to thank you for that engaging discussion, Dr. Fernandez and Dr. Lorenzo. So to summarize, we learned lung cancer is one of the leading causes of mortality in the Philippines and globally due to the lifestyle and environmental changes of the present times. Oftentimes, they manifest clinically in the later stages, which brings us to a dilemma as to what kind of treatment to give. So in the Philippines, we have chemotherapy using platinum buds, which is a non-specific mainstream type of management aimed to kill tumor cells. However, with advances in molecular genetics. We have detected now mutations in certain cell membrane protein receptors, which have been attributed to be an important pathogenetic event leading to tumor growth. We have tyrosine kinase inhibitors that prevent a cascade of intracellular events, preventing, of course, this tumor growth with better clinical outcomes compared to chemotherapy, especially in those with detected mutations. And finally, immunotherapy is the latest type of a treatment for lung cancer. It is targeted and definitive, harnessing the body's own immune system to combat cancer cells. These checkpoint inhibitors are also known as monoclonal antibodies, which enhance cytotoxic T cell activity by counteracting the tumor evasion properties, which is, of course, a more promising and definitive treatment for lung cancer. So, after this session, an email containing a survey link will be sent to you. After answering the survey, your certificates will be sent to you. Please answer the survey so we can assess our webinar and address more of your preferences and give you materials for this session. Thank you for joining us. We would also like to thank our sponsor, MSD, and the Philippine Daily Inquirer, and the Filipino Doctor for their support as media partners. We hope to see you again in the upcoming webinar on October 5, Wednesday, 12 noon to 1 p.m. Manila time, with speaker Dr. Richard Yonko on congestive heart failure. Please invite your colleagues to join this continuing monthly CME webinar series. All webinar schedules and resources will be posted at http://facebook.com/UPMedWebinars. You may also subscribe to our mailing list at http://bit.ly/UPMweb-mailinglist-2016. You may also email us at upmedwebinars2016@gmail.com for any inquiries. On behalf of UPCM Class 1991 and the UP Medical Alumni Society, we also thank our collaborator units, UP Manila Information Management Service, National Telehealth Center, UP College of Medicine Postgraduate Institute of Medicine and Medical Informatics Unit, DOST ASTI, and Ms. Charisse Orhalo of UP Telehealth, our host. This is Dr. Marisha Recto, together with Dr. Gary Lorenzo, Dr. Marisha Fernandez, and the UP Med webinar team closing this session. We hope you have learned a lot from today's webinar, and join us again on October 5. Have a great week ahead.